Hi guys, welcome back to the channel. So we are starting with a new series which will help you to deal with all the common patient presentations in OPD. In this series, we'll include only short videos of around 10 to 15 minutes which will give you the basic knowledge and concept of each clinical condition. So let's start with today's topic, that is approach to a patient with cough in the OPD. First of all, cough performs an essential protective function for our airways and lungs. However, excessive cough can be bothersome and can cause multiple problems. Now, when we consider the classification of cough, it is classified on the basis of duration. So, acute cough is said when it is present for less than 3 weeks, subacute when it is present for 3 to 8 weeks, and chronic cough is present for more than 8 weeks. And chest radiography has to be ordered for each and every patient of chronic cough. Now, what can be the various causes of acute cough? These include acute respiratory tract infections, then aspiration of food, any foreign body, etc., or inhalation of noxious substances. Inhalation of noxious substances like smoke, certain toxic gases, chemicals, etc. Now, in subacute, we have an entity known as post-viral tussive cough. So, this is a persistent hacking type of cough which can persist after the viral upper respiratory tract infection has subsided. When we consider chronic, this is the one which occurs due to various cardiopulmonary conditions which can be inflammatory, which can be infections, certain cancers, neoplasm of cardiopulmonary system, or other cardiovascular disorders. Now, as we discussed that in each and every patient of chronic cough, we have to order a chest X-ray. If the chest X-ray is abnormal, we will identify whether there is an inflammatory infection or neoplasm of cardiopulmonary system. If the chest X-ray is normal, we would suspect any of the four conditions. This could be cough variant asthma, in which the patient typically has a cough predominant finding, that is, shortness of breath is not predominant and cough is predominant in this type of asthma. Then gastroesophageal reflux disease, post nasal drip can also lead to chronic cough with normal radiograph. And drug induced cough, the most common drugs which you all know is ACE inhibitor. So these four conditions are responsible for more than 90% of the patients of chronic cough which are having normal chest radiograph. Now, post-bronchitic cough is also a common cause of chronic cough. It is a dry, irritative cough which persists after some respiratory tract infection, and it is common in winter months. Now, since you guys are sitting in the OPD, you must all know the common causes of cough. So let's discuss certain common causes. So the most common causes include common cold, influenza. Then patient can have allergies and bronchial asthma. Acute cough can be due to inhalation of an irritant like smoke, dust, chemical, or a foreign body inhalation. Then bronchitis can be there, which can be acute or chronic. Then COPD, pneumonia, acute as well as chronic sinusitis. Tuberculosis is common in developing countries. GERD, heart failure, rarely lung cancer, and use of medications. Most common which we have discussed is ACE inhibitors. So these are the common causes of cough which all of you should keep in mind while seeing the patients in OPD. Now comes the most important part. Since there is limited amount of time which can be dedicated to each patient in the OPD, each step which we should follow must be relevant. So let's see what all points we'll ask while taking the history from the patient. Firstly, we'll ask for the character of cough, whether the cough is dry or productive. So, dry cough is commonly seen in chronic conditions like COPD, bronchial asthma, or CHF. while productive cough indicates a infective etiology. We'll also ask whether there is hemoptysis present along with cough. So we have already made a detailed lecture on hemoptysis, which you can check out. Also, we'll see what is the color of sputum. We'll ask the patient as well as see what is the color of sputum, which also helps us identify the etiology. Then we'll ask what are the various exacerbating and relieving factors. This is especially important in cases of bronchial asthma, CHF. For example, in CHF, cough will increase in lying down position and will decrease in sitting or standing position. Then we'll ask the associated symptoms. What are the systemic features? Is there any fever, chills, sweating, weight loss? So fever, chills, sweating, these will all indicate infection, and weight loss, especially significant weight loss, should always give the suspicion of tuberculosis or carcinoma. Then cardiac pulmonary symptoms like dyspnea, chest pain, we have to inquire, sneezing or presence of postnasal drip, and we'll also ask for GI symptoms like heartburn to rule out GERD as the cause of cough. Then we can also ask about the severity of the cough. So this has to be asked so that we can compare the severity in the follow-up visits of the same patient. So we can ask whether the cough is affecting the work or sleep of the patient, whether it is causing urinary incontinence, and sometimes cough is so severe that it can also lead to syncope, which is neurally mediated. Then we'll ask the timing of cough, whether the cough is acute or chronic. We'll classify according to the classification which we have seen. We'll ask the duration, for what time the cough is present. We'll ask whether the cough is morning predominant or nocturnal predominant. This way we can rule out certain conditions. So morning predominant cough is seen in bronchial asthma, and nocturnal cough can be seen in CHF as well as tropical pulmonary eosinophilia. Then we have to ask for the relevant past medical history, whether the patient is already a diagnosed case of asthma, atopy, whether the patient is having any drug allergy, whether the patient is having exposure to TB or other infections or not. Then we will ask relevant social history regarding travel. So this travel history is also very important because certain infections are there. In some countries there can be outbreak of certain infections. What is the occupation of the patient? Occupation to rule out any occupational lung disease. Then addictions like smoking, which can lead to bronchitis, and exposure to pets, or is there any pet in patient's house? So this can also be asked in the social history. Also we have to ask the family history regarding atopy, asthma, eczema, and exposure to TB, that is presence of a TB case in the family of the patient. Coming on to the relevant examination and investigation. So first of all, we'll see the general appearance of the patient. If the patient is very much emaciated, it can point towards the diagnosis of chronic conditions like tuberculosis, carcinoma, or COPD. We'll see the vital signs of the patient like BP, respiratory rate, SpO2 as well as pulse rate. We'll check locally for nasal passage, any sinus tenderness is present. We'll examine the throat of the patient as well as lymph nodes to rule out any infective etiology. Then we'll go to systemic examination. First we'll examine lungs. We'll see on inspection whether there is any accessory muscle usage, any accessory muscles are used or not, any retractions are present or not. We'll then do percussion, auscultation in the steps as mentioned in the textbook. So this is the all part of examination. We'll also do CVS examination. This is also important because conditions like valvular heart diseases like mitral stenosis can also present with cough and pulmonary edema. For investigations, the first line investigations include chest X-ray, then CBC with absolute eosinophil count, which will help us rule out asthma, atopy, and if we are suspecting an infective etiology, we can also order sputum culture. If we are suspecting TB, we should order sputum CB0. Now, what can be the causes of chronic cough with normal radiograph? So, as we have already discussed, the causes. So, chronic cough is one which is present for more than 8 weeks. We have to do radiography in all the cases of chronic cough. If on radiography there is no abnormality detected, then in more than 90% of the cases, the causes include use of ACE inhibitor, post-nasal drip, GERD or cough variant asthma. So more than 90% of the cases of chronic cough with normal radiograph is due to these 4 conditions. Now there is a new entity, cough hypersensitivity syndrome. It is a recently recognized entity in which patient presents with dry or minimally productive cough and a tickle or sensitivity in the throat which is worsened during talking, laughing or exertion. It is more common in females as compared to males. It can last for years and for treatment, tricyclic antidepressants can be tried. Now let's discuss the basic treatment which you can use in the outpatient department. First and most important thing is once you diagnose what is the underlying cause of cough, you have to treat that underlying condition. This should always be sought and treated. Now we have symptomatic cough medicines which are divided into 2 types. These include cough suppressants and cough expectorants. So cough suppressants are used for dry, intractable, non-productive cough. There is no sputum production. The cough is intractable and is bothersome for the patient. In this case, we will use suppressants. The examples include dextromethorphan, which can be used in the dose of 10 to 20 milligram every 4 hourly. Another example is chlorpheniramine. So these are the cough suppressants. On the other hand, expectorants are used for the patients who have productive cough. These help in clearing the thick tenacious sputum from the airways, clear the airways and help relieve the breathing of the patient. Example of expectorants include guaifenesin. Then we have bromhexin and commonly we use ambroxol. So these are the various cough expectorants. So ambroxol is typically used in a dose of 60 to 120 milligram per day and it has to be divided into 2 to 3 doses. So this was all about the basics of cough, how to approach a patient. Especially this video will be helpful if you are recently starting the practice in OPD. This is also helpful for interns who are sitting in the OPD, PG students as well as final year MBBS students. I hope you like this video. Thank you so much guys.